Okay, the next question is about a 79-year-old female, and she is on warfarin for AF, presents with melena, which is bleeding per rectum. So her blood pressure was a bit lowish, heart rate was increased to 100 beats per minute, and the lab results showed hemoglobin of 9 gram per deciliter. She was anemic. The MCV was normal. INR was increased to 7.2, and a PR examination confirms melena. So you'll see blackish colored stool. So what is the best option for correcting the coagulopathy? Do we give fresh frozen plasma? Is it IV vitamin K? Do we stop the warfarin? Or do we stop it and give IV vitamin K? Or do we stop warfarin and give IV vitamin K and prothrombin complex concentrate? So what is the answer? So the answer is E. Okay. Stop warfarin, give IV vitamin K, and also give prothrombin complex concentrate. So this patient is hypotensive and tachycardic, with melena suggesting a major bleeding episode on warfarin. And in this condition, current guidelines suggest to stop the warfarin, give IV vitamin K, and either fresh frozen plasma or prothrombin complex concentrate. So depending on where you work, you can refer to your guidelines that is used in your hospital. But if you're not sure, then you can consult with the hematologist on call. Fresh frozen plasma may not completely reverse the effects of warfarin, and that's why it's now preferable to consider prothrombin complex concentrate (PCC) if available. And since that the rate of fatal hemorrhage, meaning that the hemorrhage that leads to death in patients receiving warfarin is about 1%. Therefore, it is vital that we know and doctors know about the reversal of warfarin coagulation. Okay, the next question is a 61-year-old gentleman presents with hematuria, blood in the urine. So he's on warfarin for chronic AF. His full blood count was 112 grams per liter, and which is a bit slightly lowish for a man, and his INR is 9, and the patient is hemodynamically stable, so blood pressure is good, heart rate is okay, and the consultant on call advises that this patient needs reversal of the warfarin. So of the following, which would be the blood product or blood products of choice? Is it cryoprecipitate? Is it fresh frozen plasma or prothrombin concentrate? Is it packed cells? Is it platelets? Or is it recombinant factor 7? So quite similar to the previous question in some ways. So the answer would be B, which is fresh frozen plasma or prothrombin concentrates. So this is the answer. So at this stage, packed cells are not indicated yet. And of course, cryoprecipitate and recombinant factor 7 and platelets are not indicated to reverse the effects of warfarin. Okay, next question is, a 51-year-old woman presents to the ED with right-sided pleural pleuritic chest pain, and she had 2 previous pulmonary embolism, so 2 previous episodes of PE, and she's on lifelong warfarin therapy. On examination, she's short of breath, she's in pain, blood pressure is lowish, pulse has increased, she is tachycardic, auscultation of the chest is normal, she has a swollen left leg, and she tells you that this is chronic since having an extensive deep venous thrombosis a few years earlier. So hemoglobin is normal, white cell count is normal, platelets are normal, serum sodium normal, serum potassium normal, creatinine normal, INR is normal, no changes on X-ray. The PeO2 is a bit lowish, and PaCO2 is also decreased. So what is the most appropriate next step? Do we add aspirin to a therapy? Do we add clopidogrel? Do we increase the INR target to 3 to 4, meaning we have to increase the dose of the warfarin so that there is more bleeding, okay, sort of, or you increase it further, increase warfarin so that the INR or PT target, prothrombin time target to 4 to 5, or do you refer for an inferior vena cava filter? So since that she is already on warfarin chronically, but again got another pulmonary embolism, so we have to either consider increasing her INR target to 3 to 4 or consider an inferior vena cava filter. So contraindications to anticoagulation where an IVC filter may be considered include having hemorrhagic stroke, recent neurosurgery or other major surgery, major trauma, and evidence of active internal bleeding. Other contraindications include pregnancy, frequent falls, and poor potential compliance with warfarin. So in these situations, an IVC filter may be the most appropriate choice. And given that she's young and she has potential for further pulmonary embolisms, pulmonary emboli, so a filter may be considered ahead of increased warfarin dose. Besides that, IVC filters may also be considered for prophylaxis in patients who have a diagnosis of cancer or who have a DVT and are about to undergo surgery. So in this case, anticoagulation may result in more problems than filter placement. Previously, patients who need to undergo an MRI, magnetic resonance imaging, are considered to be relatively contraindicated to have a filter placement. But nowadays we have MRI-proof filters, and so this is no longer a problem. So we'll see you guys in the next presentation.